after we're done today. We'll also send it out by email. So Jackie, recording started. Okay. So today is, where are we going next for screening? Developmental, social, emotional screening, and trauma pilots happening throughout the state. There's actually a lot of innovative work happening in the state of Maine around social, emotional, trauma screening. We want to talk today about how that relates back to some of the work that we've been doing around developmental screening, as well as some of the work that's happening out in the communities. Today's speakers are Sue Mackey Andrews. Many of you know her. She is one of the founders of the Maine Resilience Building Network, or MERBN. She also has been working on our Developmental Systems Integration Project. Dr. Steve DiGiovanni is a pediatrician at Maine Medical Center's Pediatric Clinic, and Rebecca Hoffman-Frances works at Maine Behavioral Health Care. And I'm Amy Belisle. I work for Maine Quality Counts. And I just want to mention that this webinar is funded as part of our Developmental Systems Integration Project, supported by Maine DHHS through funding from the U.S. CDC Preventive Health and Health Services Block Grant. Quality Counts is working to improve the health of everyone in Maine. We bring together people who give, get, and pay for healthcare to address shared priorities. Some of you may know that we founded about 5 years ago the Maine Child Health Improvement Partnership, or MCHIP, whose mission is to optimize the health of Maine children by initiating and supporting measurement-based efforts to enhance child health care by fostering public and private partnerships. And our vision is that all practices providing health care to children will have the skills, support, and opportunities for collaborative learning needed to deliver high-quality health care. There are many public and private organizations throughout the state who are working with us on initiatives. We're also part of the National Improvement Partnership Network, or NIPIN. There's approximately 25 other states that have child health improvement partnerships, and we work with them on projects, we consult with them, and we talk about what's happening, what's new in the world of child health care quality improvement. Just a few notes for today's webinar. We are now using the Zoom platform so that you can see the speakers and also get the audio through your computer. You can mute your line or take off your video screen by changing the settings on the bottom box of your screen. If you scroll down to the bottom, you'll see a mute, like a microphone button, and also a stop video. If there's conversation going on in the back, we would appreciate it if you would mute your screen. We also have a question and answer or chat functions. Please feel free to put questions in throughout the presentations. We do have a lot of slides today, so we'll probably hold questions until the end of each of the presenters are completed, and we're happy to answer questions at the end if we run out of time through email. We will unmute the lines at the end, though, so that people can ask live questions to our speakers as well. I just want to note in terms of disclosures that today's speakers don't have any relevant financial relationships with any manufacturers of commercial products or the provider of commercial services discussed in the CME activity. We will offer continuing medical education for participants who have signed into the live webinar. If you have multiple people at one computer, please type their names and email addresses into the chat box for our attendance records. We don't have separate nursing CEUs, but you can get a CME certificate. And what happens is after the webinar, we take all the attendance, and Jackie will send out the CME evaluation survey via SurveyMonkey. Please complete it within a week, and then Jackie will try to send out the certificates within 1 month of completion. So today we actually have 3 speakers talking with us today, and we're hoping to provide an overview of Maine's collaborative efforts focusing on social emotional learning and development for our youngest Mainers, provide brief updates on the developmental screening initiative in Maine called DSI, and also the Reaching Teens work that's happening around adolescence. And some of you, I think, attended the training by Ken Ginsberg back in October and November. We're also going to discuss some innovative work happening around ACEs and trauma screening and some initial lessons learned. So our first speaker today is Sue Mackey Andrews. Many of you know her. She helped to co-found the Maine Resilience Building Network, which works to create conversations about adverse childhood experiences across multiple sectors across Maine. She's one of the co-facilitators, and she's provided training and technical assistance in all 16 Maine counties to over 12,000 individuals. She works both locally and nationally on the issues. She's a member of the Maine Children's Growth Council, MCHIP, and the Coalition of Advancement of Child and Adolescent Mental Health. She was the recipient of the 2014 Maine Children's Trust Child Advocate of the Year Award and has received the Maine Children's Alliance Directors Award. So we're delighted to have Sue join us today and for all of her expertise and her continued work throughout the state. We have Dr. Steve DiGiovanni. Dr. DiGiovanni is a practicing pediatrician with a practice passion for improving health outcomes for children. He's had experience in both private practice and academic pediatrics. He's currently the medical director for Maine Medical Partners Outpatient Clinics. He's really been one of the driving forces around trying to get the trauma history questions installed throughout Maine Health, and he's been working a lot around ACEs and resilience in the clinic, in addition to all of his other job activities and titles. So we thank Steve for joining us today. Rebecca Hoffman-Frances is the Director of Clinical Innovation at Maine Behavioral Healthcare in Portland and Assistant Clinical Professor of Psychiatry at Tufts University School of Medicine. She has managed multiple large federally funded projects that focus on providing care and treatments for children and families that have been exposed to violence and other types of trauma. She's a licensed marriage and family therapist with extensive knowledge of trauma and its effects on children and families, as well as implementation science and change management. So we welcome her. I'm going to pause for a minute and see if we have Sue ready. There we are. Hi, Sue. So Sue, I'm going to turn it over to you. And do you want me to advance the slides or do the stop so you can do the screen share? I think you're still on mute, Sue. Okay. I think we're good. Screen. Can you just minimize that? Do you see where you hit the screen share on the bottom, share screen?
Right. I don't have the presentation open yet because we just gotten our computer up when you started. Can you do the screen and advance the slides or no?
Yes, I can. Okay. You're on.
Thank you very much. So it's really a pleasure to be here with everybody, especially sitting here with Steve and Rebecca to talk about some of the great work that's happening here in Maine, focusing on the social emotional learning and development of very young children, screening and early identification. And so I would like to start and give you a little bit of an update on the Social Emotional Learning and Development Initiative, or SELD. And on the next slide, it provides a little bit of background, talking about how did we all get here. Several years ago, in a variety of settings, including at the Maine Children's Growth Council, at the Maine Resilience Building Network, in the early care environment and other settings, early care and education providers and others really started talking about the tremendous increase in children under the age of 6 or 7 that people were seeing with significant behavioral challenges, and talking about how these were affecting children's learning, their participation in early care settings, and certainly their effects on the whole classroom and upon the teacher interactions with children. And we really started to look at this problem a little more closely, discovering that Maine has the second highest rate of suspension expulsion of very young children from early care and learning center settings in the nation. And this really brought us to bring this issue to the Joint Standing Committee on Education and Cultural Affairs about 1.5 years ago, and shared our concerns not only with respect to learning, but also the preparation for all children to be successful in school. And the Maine Children's Growth Council, along with the Maine Children's Alliance, was commissioned to do a study focusing on social emotional learning of very young children in Maine. We first met in August of 2015, and we're really fortunate to have the Maine Children's Alliance leading this work for us, bringing in national experts from the Ounce of Prevention, the National Center for Children in Poverty and 0 to 3. And those folks were really incredibly helpful in making this study as comprehensive as it has been. Through this partnership and the participation of a significant cross-sector SELD team here in Maine, we developed a survey that was sent out to a variety of early care learning programs, including pre-Ks and kindergartens. And we received 474 responses to that survey. And many of our hypotheses, including that we were seeing an increase in kids with challenging behaviors, were validated by 92% of the participants. Our primary outcome in looking at this work is truly not necessarily related solely to suspension expulsion. That was a really fortuitous opportunity because this was happening about the same time as the new child care regulations were promulgated from the federal level and sent down to the states for local regulatory development. But it's more so to ensure the positive development of very young children, their participate in early care settings, and for teachers and parents to be supported, as well as children, in a variety of early care settings so that they can really maximize their participation in these programs and services. Our work was accomplished with subcommittees looking at data and research in 6 areas, and you can see it's the wide array of the infrastructure around early care and development, including parent engagement, professional development for providers, the work that goes to identify children with behavior problems, and its interface with special education. And I will share with you that all of these materials, the reports and the work of the subcommittees, are located on the website of the Maine Children's Alliance. Very soon, the Growth Council and the Alliance and others will be presenting to the Education Committee of the Maine State Legislature. The top priority recommendation is really to provide early childhood consultation services to programs serving very young children, not only for the children, but also for the teachers and their families, in really looking at how the environment's contributing to challenging behaviors, intervention strategies, and support for teachers and families in supporting children to be very successful. And all of this work has really generated a variety of conversations, not only at the Maine Resilience Building Network, but also at the Maine Children's Growth Council, to really wonder about what's happening here. And there are a number of things, and I know as Steve and Rebecca talk about their screening, you'll see the connection here, but we wonder several things, and you can see them summarized here. What's really happening in terms of the social determinants of health as they contribute to child behavior, toxic stress, and the kind of relationship in the behavioral response that we're seeing in young children? How's the erosion of our safety net impacting young children and families? And what's the impact of adverse childhood experiences on behavior during these first early years? Several of our practitioners have wondered out loud, is what we're seeing in very young children really post-traumatic stress syndrome rather than mental health or behavioral problems? And our sending mission, of course, as we continue this work, is to figure out a way that we can best support young children and parents and teachers to ensure good outcomes. So again, you can see all of those materials on the Maine Children Alliance website. The next update that I'd like to give you, and many of you have already participated, I'm sure, in the updates of the Developmental Screening Initiative, the DSI. This really comes out of some earlier concerns that probably are, I want to say, maybe 10 or 12 years old. Really wondering about, are we identifying children as early as possible and referring them for early intervention services or some kind of a supportive intervention? We know that surveillance, which is the common practice in pediatric and family care settings serving the pediatric population, really detects fewer than 30% of children with developmental disabilities or delays. And we also know that the ASQ, which was primarily developed as a parent-completed screening instrument, has a 97% accuracy. Parents really do know how their children are doing developmentally. And what we like to wonder about is, how is their development being observed by the parent, how might it be influenced by the parent, and how we support parents in understanding development in a more robust way as one of the major protective factors to healthy child development. This timeline really identifies for you over the last 7 or 8 years how this work has taken fold. Starting way back when, some work that IHOC through Qualidigm was leading at the same time that the Maine Children's Growth Council was looking at these issues, we merged our work, and you can see the progress, including the fact that through the First Steps initiative at Quality Counts, more than 100 primary care practices have been trained in screening. Work has been done in partnership with Maine Care at the DHHS around claims and helping people understand how to do the screening as well as invoice for it for reimbursement. During this time also in 2015, we had 3 pilot sites, Waterville, Bangor, and Midcoast, to really spend time looking at how do we ensure that every child gets a comprehensive developmental screen, cross-sector, and that we share results so as to avoid duplication, but also to ensure that children get referred and that we close the loop on referrals for children who need services. We are now moving into a phase that's kind of twofold. There is a 4th pilot site happening in Portland, looking at the same kind of model in terms of developmental screening across sectors. And we're looking at the Help Me Grow model, which is in place in 23 other states, which is a comprehensive referral process in partnership with 211 and a variety of other partners. And to see how that would work in Maine to help families really get access to not only essential services and supports, but specifically focused early care resources and developmental supports that they need. This screen highlights, since 2011, the growth in screening that has happened. These data are from Maine claims data, so this only represents the screenings for children birth to 3 that are performed in the healthcare settings. It doesn't reflect the other screenings that are performed by other early care programs, including child care, early Head Start, and Maine families. But you can see the robust increase over time, which is pretty substantial through the practices in terms of screening. We have, through our comprehensive cross-sector team at the DSI, identified mechanisms for developmental surveillance, identified 3 tools, the ASQ3, the PEDS, and the SWIC, that all stakeholders agreed would be tools that they would focus on using. And this is a really important step because we can now assure that people have been appropriately trained in the administration of these tools and that we're not duplicating, and that when one provider receives the screening from another, they're familiar with the form, they have confidence in the person who conducted the initial screen, and they can move forward. The other issue of screening is autism screening with the MCHAT-R, or the revision, and this is moving forward at the periodicity of 16 to 30 months. Again, a key issue here in Maine. We're seeing more children with autism, and we really want to locate and identify them early and get them into appropriate services and support. Throughout this whole process of the DSI, we have developed, in partnership with folks across the sectors, a variety of products, some of which are listed here. The next slide will show us the updated periodicity schedule, which also has the realignment of the codes and the rates of reimbursement for screening at the bottom. This reflects some new work that was done at the American Academy of Pediatrics around frequency of screening and other services that happened at the Well Child Clinic. The next slide, this slide shows a handout that's provided to parents, which is the developmental trajectory, borrowed from another state in a Help Me Grow facility, but really is a neat thing for parents that we have it on a magnet, and parents can put it on their refrigerator and use it as a handy reference and resource for their child's development. Other things that were developed in the process of our work included a common terminology chart, which I'll show you in a minute, updated Maine care billing codes for oral and preventive health, availability to the American Academy of Pediatrics Bright Futures Toolkit, and a universal sharing and consent form and other consent forms that are pertinent specifically to child development services, and a variety of resources around early intervention. And you can find all of these resources on the Quality Counts for Kids homepage under the DSI tab. And this is the terminology chart that we developed. I want to say that this took us about a year or a little bit more to develop, research, and run by all of the programs and partners across sectors to agree on the definitions between surveillance, screening, evaluation, and assessment. It's helped us to all use the same terminology and know what the other was referencing at critical points in time. This was recently updated as well to show the SWIC as an added tool. And the last update that I'd like to provide to you is about the Reaching Teens Communication Enhancement Toolkit. And many of you are familiar with the work and the partnership that we have with the American Academy of Pediatrics, as well as with Dr. Ken Ginsberg. And this next slide illustrates Ken's book, really, which is written for parents, but it's also the curriculum of Reaching Teens, which is a communication enhancement set of principles and strategies, primarily developed for middle and adolescent children, people who serve those youth, but also is appropriate in many ways for people who work with younger children or in our work with many parents that we work with. It is a 69-chapter course of study with over 450 videos and is eligible for CMEs and CEUs. Earlier, actually last November, here in Maine, we trained 27 teams, which involved 157 people throughout the state. This next slide will show you just a little bit of the data about that. We have a variety of levels of implementation of Reaching Teens, self-study, shared study with their local team, working with their host agencies to share the Reaching Teens material within the host agency, education at the community level, and obviously its generic impact on children, youth, and families. We will be doing this first round of teams through 2018, and we're using the Maine Integrated Youth Health Survey as one of our evaluation dimensions. In the 2017 iteration of the My House, the ACEs questions have been added to the youth survey. So we will have an additional source of information that we'll be able to look at and judge the effectiveness of this intervention strategy. And I think right now I'd like to turn it over to Rebecca and Steve, who are here, who are going to take it away and talk about trauma-informed developmental screening.
So, Amy, I'll have you move the slides forward for me as well, if you don't mind. Can you hear me all right? Probably on mute. Okay, so I'll give you just a very quick background and just to say that I'll move through these slides very quickly. We have quite a few of them, and really my slides at the beginning are really just to give you an overview of ACEs and why Dr. DiGiovanni and I really took this on as a focus area. My work is in mental health and particularly in childhood trauma, and so really my work and understanding around the impact of trauma has been it's been very powerful to see both firsthand from the kids I've worked with the impact of trauma, but also from more of a population health perspective and a general health perspective to see the impact. At Maine Behavioral Healthcare, we've had some large federal grants, and one in particular was a Department of Justice demonstration project. We were one of 8 sites nationally to be chosen to really look at some ways to make impact in the area of childhood trauma and child victimization in particular that were different than what had been done. We proposed to work with pediatrics in Portland, and particularly with Maine Medical Center, and at the beginning, the goal was really to strengthen our feedback loops between pediatrics and nurse home visiting. And the goal was to have screening happen for childhood trauma in nurse home visiting that could then be communicated to the pediatrician in a way that would allow better support for the whole family. We were really looking at domestic violence in particular. And this was a very small goal that then exploded into a huge change initiative in Maine Health, Maine Medical Center, to begin screening for childhood trauma. And really what happened was a strong partnership with Dr. DiGiovanni and this sort of eye-opening experience of seeing the impact of trauma on child health and wanting to make a very powerful impact on that issue. And so what we changed from a very small goal of increasing the feedback loops turned into embedding ACEs screening health system was being screened for broadly their history for victimization and risk of child trauma, and then really an algorithm for response. And so Dr. DiGiovanni will talk more specifically about the screening, but I just want to really give a broad background of why we're doing this. So you can move forward, Amy. So for those that don't have history of really looking at ACEs and the impact, I'll go through these slides quickly because really one after the other you'll see that the link between adverse childhood experiences and other health issues or risky behaviors is incredibly strong, the correlation and the relationship. So this slide here really looks at ACE score. So what an ACE score is really looking at the types of trauma or adverse childhood experiences, I use those interchangeably, a child has been exposed to. And so an ACE score of 1 means they've been exposed to one type of adverse childhood experience. An ACE score of 4 means they've been exposed to 4 types. So that might be neglect, physical abuse, sexual abuse, and let's say an impaired caregiver, which is often substance abuse. So, so really we're looking at a correlation here in this slide of risky sexual behaviors and ACE score. And as you can see, as an ACE score goes up, so does the risky behavior. So you can move on, Amy. So again, we're looking at chronic depression and adverse childhood experiences. And again, you're seeing a dose response here. You're seeing the increase of a dose of adverse childhood experiences or toxic stress and an increased response in chronic depression. And it's interesting to see the gender difference in that one. It's not surprising to me. And here again, this one's a very powerful slide. It's probably one of the most powerful ones with a link between suicide attempts and adverse childhood experiences. Now, as you'll see in these slides, really the sort of tipping point for kids is 4. When kids have been experienced 4 or more adverse childhood experiences is when you really see an increase in a major increase in health issues and risky behaviors. And as you see with suicide attempts, this shows true. Again, here we're looking at health outcomes, so diabetes, cardiovascular disease, and cancer, very expensive and common medical issues. And as you can see, again, as the number of adverse childhood experiences go up, so do the number of cases of these chronic diseases. This one, again, another very powerful one between drug abuse and adverse childhood experiences. And from the mental health world, what this speaks to us about is really a need to, an ability to cope. So children and subsequently adults learn to cope with the impact of trauma in different ways. And here you're seeing, for us in the mental health world, that many people are numbing their trauma experience with drug use, and also as you can see in this slide, same with alcoholism. So So in Maine, through our grants, we did our own research on the children that we were seeing in treatment and their exposure to traumatic experiences. And really what we found in Maine was not different, actually a little bit higher than the rest of the nation in terms of exposure to trauma. So the kids in our data set were all in trauma treatment. So 100% of them had been exposed to trauma. But we found that on average, those kids had 5 different ACEs, and so it's a little higher. The national average is around 4, and kids in Maine had 5. Now, interestingly, when we looked at the data by county, we found that children in the more rural counties, the rim counties, had an average of 7 types of trauma. So when you think of that dose response, we're talking about a very, very high level of dose of trauma. And so it's really impactful when you think about those children growing up, their health, their risk of risky behavior, substance abuse, and so on. So clearly we had a major issue. And here, this is a national slide on homelessness and ACE score. And again, a much, much higher level of homelessness with kids that have grown up with a number of ACEs. So really what you're seeing is a major issue, a major health issue, one of the most impactful health issues of our time, really. And so from a medical standpoint, it's absolutely critical. We decided to address this in the medical setting. So I'll let Dr. DiGiovanni sort of talk about how we addressed it.
So for a big health system like Maine Health, we couldn't just dive in and start asking all of the ACEs questions. And so our initial approach was to really kind of get a foot in the door. And the easiest way that we looked at was there's kind of this expectation that we ask safety questions. Do you feel safe? That's based mostly on adult research in domestic violence and did not feel like it was being effective in our practices. So through a steering committee, we settled on these 2 questions you see on your screen. The first is a kind of taking a safety question and broadening it to home, neighborhood, school, and relationships. And then the second one, which using some AAP recommendations and some other article research, is how we got to this question. And our steering committee: has anything bad, sad, or scary happened to you or your child recently or in the last year? So that we had that built into Epic. We developed workflows and provided trainings at our sites. It was a kind of what I would describe as a soft rollout, meaning there wasn't any full expectation that every practice had to do it, but we tried to be as persuasive as possible. Next slide. In addition, into the EMR, we built a symptomology screener for PTSD symptoms. We found this to be very helpful, whether you had it just on paper version or in your EMR. And it changes a little bit depending on the age of the child. But what we found is most pediatricians just were not trained in subtle or even more impressive PTSD symptoms. They do change based on your developmental stage, but here you can see it is a nice quick screener. And working in the resident clinic, it has definitely been an excellent teaching tool for the types of questions that you might ask. Other things we built into Epic were instructions for parents of children who are exposed to trauma, so those could be printed off and handed to them, and it had helped children respond at different developmental ages and some language you could use with the children and parents. So as part of this, we were able to get some, we built it so we could track it. The expectation, just so you understand from a workflow, is it was asked, the 2 questions were asked during the rooming process, and they could either be asked by the MA or some practices used a handout. If it was any of them were positive, the expectation is the MA would update the physician, not just put it into the EMR because we didn't want to miss something. And then it was up to the physician to find out what the actual issue or exposure was, decide if you do the PTSD-RI, and to decide on the referral process. Most of our practices have some part-time integrated behavioral health clinicians embedded, which does help when you're pursuing these types of questions. On your screen, you can see, so our data over about a 6-month period. Actually, I think it's about a 9-month period. There's almost 12,000 well-child visits. At about 7,500, we did have the trauma questions completed, and the positive risk came back at about 6%. When you looked at the individual offices, though, it ranged like from month to month from 2 to 17%. When we dove deeper into the data, we could see that the safety question really was not the one that was getting the positive. So of the 524 in the second data set here that were positive, only 5% were from the safety question, while 92% were from the positive, sad, scary, or bad question. And so that to me was a major, major change in how we try to kind of approach these questions. We did go a little bit deeper into the data. If you want to go on the next slide, Amy. It does make a difference, and it's one of the kind of learning points of how you collect this data. So 2 of the clinics were using de-identified handouts that were just handed to the families at check-in and then entered by the MAs. And then the other practices were just having the MA ask the questions as part of their kind of rooming, vitals obtaining clinical check-in. And you could see almost more than a doubling rate of the positive risk. Obviously, I believe there are some differences in the populations, but not to the point at which you would explain this risk differential. So for the 2 practices, you can see all the way up to 11% of the time there was a positive risk coming back. And when the 3 main practices, you could see kind of in the 3 to 4% positive risk range. We were lucky to have an intern who could look into the types of information, because you want to know, is the information that we're gathering true major issues that we need to be worrying about? And this kind of gives you a count, of those 500, how many times that we saw a physical assault, a school violence, sexual assault, neglect, abuse, major mental health issues, bereavement, separation, and you can kind of see them rise up. What impressed me about this is that of all the categories from the National Traumatic Stress Network, National Child Traumatic Stress Network, we hit every category except trafficking and sexual exploitation. So we were getting some powerful data coming out of this one question. There's a big other category here, and we are aware of that. A lot of things there were kind of loss of, like multiple types of loss of home or stressors from, there was multiple fires to one family and stressors of being able to find a home to be able to afford, and kind of some multiple other issues. Next slide. When we looked into the charts, 44% of them had 2 or more types of trauma noted. I also already highlighted that we covered almost every type of trauma category. People did use the PTSD-RI, not every time, and that's not the expectation, but if it is a significant event, we do advise it. And of the times it was used, 21 out of 54 were positive. And the referral data, I got to check because that doesn't match up. The next referral level showed that of the 524 kids, 118 of them had referrals, primarily to either community resources for mental health support, case management, or to the integrated clinicians within the offices. And then 56 of the 118 who were referred were already seeing a mental health provider, so probably kind of multi-issue families there. Next slide. So that was our first kind of step into the world of screening for ACEs. And it really, I do want to acknowledge it is the first step, but I do feel that we gathered significant events that were impacting children. In my own clinic, we have a full-time behavioral health MSW who we do lots of warm handoffs right off of these types of questions. And or if she's not available, we set the appointment up prior to the patient checking out. The next thing we dove into was looking at developmental screening. Up to this point, Maine Medical Partners was just using developmental milestones, and which was not sufficient from an accuracy point of view. When we looked at which screening instrument to choose, we did compare the ASQs, SWIC, and PEDS. When we looked at the data around ACEs and kind of the frequency of mental health disorders and obesity, the only reason we chose, that was the main reason we chose the SWIC, is it was the only screening test that really took that wide-ranging approach and really looking at the entire family. Some of the data that we were able to look at is you look at, this one is ACEs against developmental delay, and similar, when you hit 4, you've jumped all the way up to greater than 40% of the kids have developmental delay. At 5, almost 75%. So if you're not screening for that, in my mind, from a population health point of view, you're missing the boat from developmental delay. So we wanted it to be part of how we approached our developmental screening. Next slide. There's similar findings when you look at children of school age and the risk of having academic concerns. It has that also stepwise approach that each time you add ACEs, it goes up. So if you 3 or more ACEs in this school district, 80% of the kids had an academic concern. So once again, by looking at this, trying not to miss the boat around the child's development. Next slide. For anyone who's not familiar with the SWIC, I like the circle approach. It's really trying to wrap around the entire family and child. It has a developmental milestones section, which is kind of a classic validated developmental screen, shorter than the ASQ, but with some good research behind it. For the appropriate ages, it does have an autism screen, the parent's observation of social interaction. One of my favorite sections is the behavior and emotional health, which really looks at the child's behaviors and parental challenges, and is a great way to initiate conversations with parents about their children and parenting styles. And then the family stress really is kind of built around an ACEs approach. It's not fully built out at this point, but it does touch on multiple ACEs. Next slide. Things I like about it, it's pretty easy for families, if they are literate in English, French, or Spanish, to fill out. It's the questions I find simpler than many of the questions on the MChat or even the ASQ. It doesn't require pictures, diagrams, or props, and it's pretty darn easy to score. Next. To understand, for any screening tests, they're usually designed to have very high sensitivity and low specificity, and that's the case with the SWIC, just like it is with the MChat, PEDS and ASQ and PHQ. What they're trying to do is identify pretty much all the affected children, so have a very high sensitivity, but the trade-off is it'll have lower sensitivity. So when you're using the SWIC, really understanding the positive score is not a diagnosis, it is identifying risk, and that you should be diving into the issue in a little bit deeper way. Next. As I said, its validity does look, and on their website, you can review all the validity studies, but it does compare to other popular screeners as highlighted there. They also did look across gender, race, ethnicity, and socioeconomic status. As I highlighted, it does the overall well-being of the family. This first slide here really shows you the developmental milestones. This form would be used from 6 months up to the day they turn 9 months. It starts with easier developmental milestones and moves to harder ones. The expectation is not that you would pass all of these for each age. You come up with a score. If you click, it'll kind of click through the scoring process. And you get a total score. And then there's a sheet that you compare it against for each age by month to see if the child is meeting age expectation or needs review. The next section is the baby pediatric symptom checklist, 3 sections looking at inflexibility, irritability, and routines, which pretty much sums up 90% of parenting in the young age group. Not at all, somewhat, and very much are the scores. If you get a 3 or above, that they say is the to review, but a 3 and really, or the very much for any of them, to me, is a place I'm going to start some conversation, and really has been a nice change in our practice. not going to spend a lot of time on the autism screen just to save time, so we can kind of flip through that quickly, but it does have an autism screening section. And then the last section is the family questions. This one's probably the biggest change for pediatrics. So if you look at the questions, there's a tobacco question. That's not a major change. But then the next one's really screened for using a validated screening tool for drug and alcohol abuse of the parent, which is not something we were doing consistently previously. In addition, there's a food insecurity question. I think this is an excellent question because the amount of stress on a family if they have food insecurity for their daily existence is very, very high. It doesn't mean that, it's my job to solve their food insecurity. We can connect the resources, but use it as a red flag that this family needs some supports. Next, there is a depression screen for the parent, very similar to doing the 2-question postpartum, why we stop at 2 to 4 months of age. Screening for parental depression probably doesn't make sense. So this brings it up in the age range. And the last section, which I would say for the first time in pediatrics, is really starting to get at that domestic violence question. I like their approach in that they're really looking at what's the relationship structure. So you can see the question, how would you describe your relationship with your spouse? No tension, some tension, a lot of tension. And do you and your partner work out arguments with no difficulty, some difficulty, great difficulty? Once again, the idea is opening up conversation, having resources that you can refer to. I would say we do need additional training and resources in pediatrics to use this to its full capability. And I would say having an integrated behavioral health clinician on your site is like a gift every day when you're doing these types of screenings. Right now, our implementation is at the 9, 15, or 18-month and 30-month visits at 3 times before the age of 3. It's distributed at check-in. Completion is supported and then by the clinical staff and scored, and then reviewed and acted upon by the provider. And you can see that really having close collaborations, especially with child developmental services, the behavior and development specialists, and behavioral health clinicians. The expectation, well, back one slide, that's nice about the SWIC is that really, I would say probably about a third are going to be, you're going to see them back yourself to kind of see where things are going. A third will probably go to behavioral health and another third to developmental specialists. So it really kind of distributes it out and doesn't overwhelm any one system. We don't have a lot of data yet on our rollout as the data build is just been completed, and hopefully in the next month or two we'll have that information. We did go out to all of the practices and provided a 45-minute training, which I would advise. We do have the training tools that we use that we got from the SWIC, but also adapted for our sites. And that was pretty well received, actually. The practices truly appreciated us coming out, going over why we're doing it, how to do it, what the resources were, the question answer session, and giving them different tools, including like a SWIC 101 that gave them some language of how you would describe it to the parent. Our presentations always include the entire staff because pretty much all staff are involved from the front desk through MA, nursing, and the physician. And I think that's the end of my section.
So just to wrap up with really what we consider an essential part of really screening for anything is to responsibly screen, you have to have resources available to support a family and to support the providers if the screen is positive. And so really 50% of the work we did in implementing the screening, and I'll really specifically talk about the trauma screening, was to make sure that resources were available to refer, and also that providers and families felt comfortable, knew about the resources, and that it was easy to refer. And so So the other half of our project, as I said, the 50% was around specific evidence-based trauma treatments and ensuring that those were available throughout the state. And the treatment that we actually utilize 3 treatment models, but the primary model is one called trauma-focused cognitive behavioral therapy, so TF-CBT. And we did a few things. We trained providers, clinicians, everywhere throughout the state in the model, making sure they were available in every county and in some of the more rural areas of many of the counties. We also, as Dr. DiGiovanni mentioned, we created discharge instructions for families. So if they screen positive, but maybe let's say they weren't ready for treatment or didn't rise to the level of needing treatment, they still had, just as you would if your child had asthma or, you know, a cut on their finger, you would receive discharge instructions on how to take care of it. We did the same for trauma. And not only does that normalize trauma as a potential experience in life, but it also provides information to the family, which empowers them to address the issue. And so the instructions included normal signs and symptoms of traumatic stress, as well as how to connect with services, how to help your child at home, how to deal with some basic sleep issues, anxiety, depression, whatever it may be. We also created, as part of a bigger project, to give families information on healthy development throughout the different well child visits. We included information on healthy relationships, on ways to connect with your child in healthy ways, ways to deal with arguments and difficulties in order to potentially reduce the likelihood of trauma occurring. And so in addition, we created these algorithms for response that were built into the medical record in terms of how to connect with evidence-based trauma treatment, what the treatments are, what they're called, how to connect with clinicians trained in these practices. So we tried to make it really readily available. As I mentioned earlier, we collected data on our treatment success, our outcomes, and just to show you, this is Maine data, that symptoms clearly over time decreased. We looked at all the sort of standard post-traumatic stress symptoms, re-experience, avoidance, negative emotions, and arousal, and in all areas, the kids in our data set, and really this is one of the most studied trauma treatments in the world. There's, you know, at this point, something like 13 to 15 randomized controlled trials in every setting for TF-CBT, and our data showed really similar results. 90% of the kids in our data set moved from symptomatic to symptom-free by the end of treatment. And so, you know, we like to show that this treatment works everywhere, but also here in Maine. Next slide. And just to show you some of the trainings that we've done as part of our Maine Children's Initiative project. The slide on the left-hand side is showing where we train clinicians, and a lot of these clinicians are home-based clinicians, so they travel too, so they aren't located just in the sites, the cities and towns that you see, but they do home and community-based treatment. And on the slide are some of the trauma trainings that we've done, the locations that we've done. We've trained every child welfare worker in the state on the impact of trauma on children, as well as resource parents. We've done trauma training academies, trained the trainers, and training on secondary traumatic stress, which has been really vital to our medical providers to train on the impact of working with kids that have experienced trauma, because it can be really impactful on your view of the world and your work. And so we've tried to really support the system in a variety of ways, and as you can see, we've trained throughout the state on that. And so again, we really believe in this screening, but we also believe that to do it right, you need to support providers and support families and have treatments available. And so having the dual leadership of pediatrics and mental health from, you know, a top-down approach has been successful for us in terms of being able to impact the effect of ACEs and trauma on children.
So Amy, would you like to facilitate questions?
Yes, thank you very much. And we do have some questions. So one question is, where did the funding come for the trauma training?
So this is Rebecca. We've had a variety of funding sources. The first that I mentioned was through the Department of Justice, and that was particularly for the screening initiative. The other funding source primarily for the statewide training was SAMHSA, the Substance Abuse and Mental Health Services Administration, through their National Child Traumatic Stress Initiative, provided funding for the treatment training and the trauma training throughout the state.
Great. And another question maybe for you, Steve, is where did you get the information for the instructions in EPIC? And how have you developed sort of patient materials around the trauma history questions as well as the SWIC tool?
The patient instructions we developed in collaboration with Portland Defending Childhood and Rebecca's group, the Justice Department funded program. So that was, internally developed, but using lots of kind of national guidelines and benchmarks on it. And what was the question about the SWIC?
Just where are you getting the materials for the families to explain it? Are you getting it? The SWIC does have a very nice website. It's out of Tufts for folks on the line who are asking. But are there other materials or other places where you're getting information for families on it?
No. Basically, we used, we've communicated directly with the SWIC team, which has been helpful. And we've used their manual, and then we basically developed some quicker handouts because the manual is extensive, that we then just used on our sites.
And another question probably for you, Steve, is around how well integrated is the screening now into your electronic medical record, and what data are you able to pull on the screenings from the EMR?
Yeah, so the 2-question screener, as you can see, we can pull the rates of those being positive, and then we can also look at if the PTSD-RI was utilized. The deeper level data was off of chart reviews. We can also, as I look at referral patterns. The SWIC, we'll be able to shortly take a look at what's the rate of completion, and then for just each of the sections, if it was needs review or passed. So it's not super in-depth yet. It's not at an ACEs level, like I'm at an ACEs score at this point. We are looking at moving in that direction in the future.
And I think that is one of the benefits of the SWIC. We like the ASQ. A lot of our community partners are using it. We've gone out to teach the ASQ a lot, but you can't build those questions into your electronic medical record. The advantage of the SWIC and why some people are switching over is because it is free and you can build the questions and the scoring into your electronic medical record. So that is one of the benefits. It might take you a little while to do it, but you can do it. So that might be a little bit of what they were asking as well. As we wrap up, I'm going to ask you guys one more question. I just want to let folks know that we do have 2 webinars coming up soon with the New England Genetics Collaborative. We have a Maine, New Hampshire, Vermont webinar on helping families and professionals maneuver the maze of complex conditions with Tara Townsend, Bonnie Thompson, and Jill Reinhart on March 30th. And on April 13th, we have Greg Marley talking about how do we better identify and manage high-risk youth suicide risk of primary care. So we really hope that you'll join us. The next piece is just around CME. We don't have any CME disclosures for today. If you do happen to be on a shared computer, just to type into the chat box your name and email address so that Jackie can send you the CME survey. And I just want to wrap up by saying 2 things. One, those of you that are in the Maine health system, I think, can contact Steve or Rebecca for additional information on the work that they're doing. If you're not within that system and you want some on-site or virtual technical assistance for developmental screening, please email Kayla Cole, who's our child health project manager, and we are able to offer that technical assistance at least through the end of September through our Developmental Systems Integration Grant. So if you need help, we'd be happy to connect with you virtually through Zoom or come on site. We have a lot of materials on our website. And just as we wrap up in the last minute, I just want to thank Sue and Rebecca and Steve very much for joining us today and working through all the technical things. And I just want to ask one last question about where do you think we're going in the state? You've done a lot of this work. You've done a lot of piloting. What do you think is the next step, and where do you want us to be in the next couple of years on this issue? It's a big question for a minute.
Yeah. Personally, I would like to see a SWIC model that goes from early childhood into, adolescence that does truly collect the ACEs data at the front line, just as, or more importantly, building up our mental health, behavioral health resources within our pediatric and primary care sites, and kind of redesigning the investment so that medical and mental health are a little more equal in primary care.
Great. Sue?
At the Maine Resilience Building Network, we sort of have this vision that, and I'll use the analogy of the seatbelt, that it took us several decades to move from where riding in a car without a seatbelt or drinking and driving were pretty accepted and common behaviors to now where I'm sure that most people have a routine of either getting in their car and putting their seatbelt on and then starting the car, or starting the car and putting their seatbelt on before putting it into gear. And we've managed to change the thinking and the public systems around wearing seatbelts, not drinking and driving, putting kids in car seats. And I think we can do the same kind of thing to create a conversation around adverse childhood experiences and the prevention of trauma or trauma reduction for children who have experienced ACEs, and make it a cross-sector conversation so that we're all talking the same language when we encounter children or adults and working together on prevention and early intervention.
Great. Thank you, Sue. Rebecca, any last thoughts to close us out?
No, I think my colleagues have said it beautifully.
Okay. And thank you very much for speaking today. Thanks everyone for joining us. We will have the webinar recording and slides up on our website. Jackie will also email out the CME surveys and the links. And I just wanted to remind some of you that Portland Defending Justice did do a nice video around resiliency that we can also share when Jackie sends that out in case anybody wants a nice animated version for their office. So thanks very much for joining us, and we hope to see you on March 30th and again in April. Thanks again.
Thanks, Amy.